It's great that we can all meet virtually today to explore the topic Greater Petaling City-wide Capacity Strengthening of Multidisciplinary Team MDT in Breast Cancer. My name is Dr. Teh Mezi and I'm a consultant oncoplastic breast surgeon at University Malaya Medical Center, UMMC Kuala Lumpur, Malaysia. To date, we have about more than 50 registrants from various medical centers in Malaysia and crossing several disciplines. Kindly let us know in the chat box if you could not hear or see us. Today's session will be split into two segments, a short introduction by Prof. Aisha and a 15 minutes talk by Dr. Sylvia McCarthy. We will then have a 40 minutes MDT discussion with 4 invited panelists from Pantai Hospital, Kuala Lumpur, and a case presentation by Dr. Harinthiran from Ampang Hospital. In case of any technical issues, please signal us in the chat. We will try to help you resolve it quickly. Now we shall begin. We will now invite Professor Nur Aisyah Muhammad Taib. She is a senior consultant breast surgeon from University Malaya Medical Center, UMMC Kuala Lumpur, Malaysia. She is currently the head of Cancer Research Institute and has about 200 publications in peer-reviewed journals. Her areas of interest are strongly correlated with patient care and outcomes. She is also the leader of the Management and Quality Technical Committee in the Greater Petaling City Cancer Challenge and a City Executive Committee member. City Cancer Challenge Foundation, CCAN, supports cities around the world as they work to improve access to equitable quality cancer care. Without further ado, I welcome Prof. Aisha.
Thank you, Dr. Teh. So welcome again to our third installation of the Greater Petaling MDT Capacity Building Project, MDT ECHO. And so we'd like to also introduce the project to all of you. So the Greater Petaling City Cancer Challenge is a 2-year program, which was a little bit delayed because of the COVID. And hence, some of the action plans that had been funded earlier by various global organizations like the Islamic Development Bank and IAEA, which funded a known action plan that has happened in most of the cities around the world who are on board with the City Cancer Challenge. So City Cancer Foundation is based in Geneva. It is really the movement of cities to address the issues of cancer control globally. So the Greater Petaling MDT project is made up of a project team led by myself, Dr. Anita Bagawi from the Ministry of Health, who is also the development head of the Clinical Practice Guidelines of Malaysia in the management of breast cancer. And we also have Dr. Izuna from the Health Technology Assessment Unit. So the three of us are leading this group of multidisciplinary team of people. You can see them in this photo. And Miss Patricia Gomez is actually one of our project team members. And she is also one of our technical committee members of the CCAN project. So basically this team have actually come up with several projects, and namely the first one is the best practices in implementing MDTs for breast cancer, which will be distributed in May this year. This document is really to help hospitals that are trying to start their own MDTs, but we recognize that most hospitals, especially the ones main hospital, general hospitals with specialists, that do not have the complete members of the MDT. So we hope that by doing MDTs, we will improve the cancer care for our patients. So this again is the third installation of the ECHO training that we have done. This is actually the third one. The first one was Dr. Ben Anderson from WHO. He's a breast surgeon from University of Washington, but he's now the WHO medical officer who actually educated us a bit about the Global Breast Cancer Initiative, which is really 3 pillars in improving or reducing mortality of breast cancer by 2040. And these 3 pillars include health promotion, and early diagnosis. The second pillar, timely diagnosis. And the third pillar, comprehensive management and supportive care. And that is why we have our third installation today, which is really on the pillar 3, to try and see how we can improve our supportive care in the Greater Petaling. And I would like to also mention, the team had been on a study visit to Tata Memorial Hospital in Mumbai, India last month, and we have learned a lot. And we hope that we can bring some of the ideas that other people in lower middle income countries are doing to improve the quality of care in their country. So with that, I think that was my last the only slide. So I'll hand it back to you, Maisie. Thank you again.
Thank you, Prof.
Okay.
I will remind everyone, if you have any question, kindly put up in the chat box below. We will try to address them as soon as possible. Without further ado, I would like to welcome Dr. Sylvia McCarthy to share with us on symptom control in breast cancer management. Dr. Sylvia is a palliative care physician and is the current medical director of Hospis Malaysia. She is also an honorary lecturer for various universities, namely UPM, and UITM. Dr. Sylvia has published in many journals and is an active editorial board member of the Malaysian Family Physician. She is also the National Technical Advisory Committee for Palliative Care and co-chairs the Standards Committee for Palliative Care Malaysia. Without further ado, welcome Dr. Sylvia.
Thank you very much for that introduction, and thank you for the invitation to present here today. I understand that the aim is really to improve outcomes for breast cancer care, and I think symptom management is a key part of that. That said, there's no way I can cover it all in 15 minutes. So I've tried to look at some basic concepts and ideas and not so much at the pharmacology. And I hope this is useful, but it's been a struggle to think how to present it well. Okay, so these are the NCCN recommendations for who should have, I'm going to say, a palliative approach to care, because we can't all refer everybody to specialist palliative care. But anyone who on screening has uncontrolled symptoms, moderate to severe distress, or serious other comorbidities, family caregiver concerns, patient or family requests for palliative care, metastatic disease, or potentially life-limiting disease. So it's not restricted just to metastatic breast cancer. It's anyone who's really struggling through their illness. Of course, if you've got any of the great list below, you should really be having a palliative care consult. I'm not sure if any of you use this screening tool. It's been well validated in oncology clinics, and I think it is quite simple for patients to get the hang of it. They just need to mark their level of distress, and then they're given a problem list in various areas to tick off the things that they are concerned about. And that gives anyone seeing the patient afterwards an idea of how they are navigating their breast cancer journey. In palliative care, so there are various symptom scores. I'm showing the ESAS, which is the score that we use. It's fairly simple. Our nurses use it quite easily. And sometimes, particularly the scores for anxiety and depression, patients don't present those things, but when they're asked to score, they might suddenly put a number of 7 or 8. And that really is an indicator to stop and say, well, what's going on there? What is happening? And sometimes they're saying 7 because my pain is so bad. So I think really key, and I'm going to spend more time on looking at assessment than anything. In breast cancer, in palliative care, we often use this diagram of 4 quadrants, which is sort of useful if you're someone who likes to organize in lists, but doesn't really represent how people are. We're far more complex than that, and everything becomes a jumble. But to help us sort it out, it's useful to think about the physical symptoms, the psychological impacts and how people are coping, the social aspects of how they're accessing healthcare particularly, and the spiritual. So the kind of symptoms in breast cancer can be related to surgery, to treatment. Of course, early menopause is a problem, and we have to think about other illnesses and metastases. So there's a lot to think about as to what is the cause of the physical symptoms. How are people affected psychologically? Well, they lose their usual roles quite often. They become someone who receives care rather than gives care. They may be a mother of young children and feel that they're not giving their children enough time. They may be high-powered corporate executives who lose their job. Of course, there are issues of self-esteem. Most of us go through life being in control. And when an illness hits us, suddenly we lose that. Body image. The breasts are very important in part of body image, but also any illness changes how you, and people are often very much affected by that. And it affects relationships. So these are all areas that may or may not be playing a role in how patients are presenting their symptoms as well. Financial aspects of healthcare, we're all too aware of, but also how we organize access to healthcare. Big hospitals are quite difficult to negotiate. And we need to consider how we can make those pathways better. And that's why I think projects like this are so important. In the spiritual section, we're talking about self-esteem, meaning, and values. So coming sort of in more detail to the physical, the same symptom is different with every patient. So we can't treat all pain patients the same. And we need to think that symptoms are multifactorial. It does require some time to take a really good history. It requires us to ask open-ended questions, to really listen carefully, clarify details, track the history of the symptoms. Perhaps because I work in the community and also because my background is in family medicine, you can make really good diagnoses just by listening very carefully to the history. We need to understand the impact of symptoms, and we need to understand the goals of care. So by goals of care, what I mean are what do the patient want to achieve? What can they not do at the moment that may be related to their symptoms that they would like to be able to do? Because patients sometimes present pain, but might not necessarily want lots of medication for pain. But if you link it to, if you manage your pain, your mobility will be better. If we focus on mobility as the goal, your management will be more successful. Of course, I've repeated, comorbidities have to be considered, and side effects of treatment. Could it be a new illness? So what are the kind of questions that we can ask? Of course, all the usual symptom questions, but also, how has the symptom affected you? How has it made you feel? What does it mean to you? How has it affected those people around you? And those questions are often, unfortunately, left out from history taking. I think people are scared of emotions quite often. If we really focus on patients and walk them through the story of their illness, that in itself can be therapeutic if we pay attention to the human experience of the illness. So when they first felt the lump, what was that like? How did they respond? What did they think? What did they feel? When they first had a biopsy result, when they went for their first mammogram or scans, what happened to them and what was happening to their family? There's a whole story there. And I completely appreciate that we don't have the time to listen to it all, but we can respond with little observations, that empathetic statements, if you like, that will make a patient feel heard. So if someone says, it was a big shock, yeah, I can see that was difficult for you. Makes a difference. We need to understand how they've been affected. Some useful questions, I've left one off, are questions that empower people. So what have you been doing that's helpful? That question tells patients that actually they are doing things that are useful to cope with. Coming on to the social area, we need to understand the environment in which they're living, the people around them, mobility issues that they might have, availability of medication, accessibility of care, and financial issues, amongst many other aspects. Because if we create a management plan for them that doesn't take those things into account, it won't work. Spirituality, there are complex definitions. I'm offering you 2 questions to ask in the spiritual realm. What is the most important to you? What is most important to you? And the second one is a mouthful. It's known as the dignity question, the patient dignity question. It's, what do I need to know about you as a person to give you the best possible care? Now, I'm not suggesting that you say that to every patient, but the concept of it is, I need to know a little bit about you as a person, as an individual, because that will help guide treatment. And obviously, we're all speaking in lots of different languages. I totally appreciate that. All I want is to share the concept of getting to know someone. So when it comes to management, again, we need to look at all of these 4 quadrants and see that within our management, we are addressing interventions that help with each aspect. So obviously the physical is pharmacological, but also non-pharmacological. In the psychological realm, it's the therapeutic presence. It's about acknowledging and validating their concerns. It's not about telling them not to worry. They might need a family conference. And I really hope that you have a psychologist or counselor that you can refer to. The social is actually very difficult to change people's social circumstances. And it's quite difficult to give people advice on how to manage their social circumstances, because they've probably really thought about all the options for themselves already. But what we can do is make sure our management plan aligns with some of their circumstances, and also that they understand their illness well enough to plan their resources. In the spiritual quadrant, if they are struggling with meaning, it's about, again, acknowledgement and validation, not giving advice, and referring on. In Malaysia, I think most patients, if they are looking for religious advice, are already linked in to their own religious communities, and we very, very rarely refer out. So coming on more specifically to pain, you can see how the 4 quadrants are important, because it is those that then create total pain. And if we just focus on managing the physical, we will never control pain completely. I'm sure you're all aware of the WHO analgesic ladder. Sorry, let's go. So I thought I'd briefly talk about how we would start pain management if the pain is severe, or if we're stepping up, having been at steps 1 or 2. So we would start with morphine, aqueous morphine, short-acting morphine, and we would start, the standard dose is 5 milligrams every 4 hours. And we would ask them to take it orally and by the clock. In renal impairment, we would use a lower dose and we would space the dose. Sorry, I've hopped straight into management, assuming that you already are very comfortable with diagnosing the cause of the pain. The key is the instructions to patient and carer. Precisely how do they take morphine? If they're sleeping through the night, they don't need to wake up to take it. If the pain occurs before the next dose, they should take an extra dose, and that doesn't mean miss out the next dose. Once we have a stable requirement, once we know what their 24-hour requirement is, we will start a long-acting preparation. There isn't that much difference between the different long-acting preparations. It's how they are given. So it's tablets versus a patch. Theoretically, fentanyl causes less constipation, but it doesn't mean they don't need laxatives. Oxycodone and MST are really very similar. The name is different, so some patients will prefer one or the other. And it also depends what your hospital, so I was enjoying the music, what your hospital stocks. Mundi Pharma has withdrawn some of the oxycodone from the market. These are just some conversions. I'm not going to go through it in the interest of time, because you can Google it. There are plenty of opioid calculators available. These are the conversions we use. The important thing is, when you're converting from one opioid to another, please check the dosing. I think the thing that people struggle with it sometimes is the concept of breakthrough pain. So most patients with cancer pain have a constant pain, but which can be controlled by long-acting opioids. But they are still at risk of having acute severe pain that needs treatment. So they should always have a rescue dose of a short-acting opioid. Until recently, that was only aqueous morphine, but we now have sublingual fentanyl, Abstral. However, the indications for sublingual fentanyl, because it's very short-acting, is for those sharp acute incidence pain, particularly in patients where you know some movement is going to provoke pain. So they can take that for that movement. Aqueous morphine is a little bit too long-acting to cover that. But how to take sublingual fentanyl is complex. I've put the instructions down there. Again, I'm not going to go through it because I think you need to check the instructions. Hopefully you have a pharmacist you can work with who can talk patients and carers through how you take it, because it's quite difficult to give good instructions. Neuropathic agents, our go-to is still amitriptyline. One of the big reasons I prefer amitriptyline, apart from that's what the evidence says, is that it's one small tablet at night. Gabapentin capsules are big, and by the time you've titrated up, you have really placed the pill burden on patients. My pain management working. Obviously, patient factors that they may not be able to manage it. There may be pill burden. They may have beliefs around opioids that haven't been adequately addressed. There may be carer factors. Of course, we might not have explained it well enough. We might not have assessed fully. We need to think about reassessing if it's not working. And there are other doctors who come into the picture as well and give contradictory advice sometimes. So it's really important to work as a team for that. And there may be changes in the disease process. So the big thing, I think, is to recognize the issues of polypharmacy. We definitely don't use more than one long-acting opioid at a time. So one long-acting opioid and a short-acting opioid. And we try and stick to one antineuropathic agent. The Australians particularly like adding paracetamol because there's supposed to be a synergetic effect with long-acting opioids. But you have to weigh that against the pill burden. And you've got to give two types of laxatives. And then they've got all their medication for their comorbidities. And they're bound to be taking supplements of some sort, hemotemics, and their cancer treatment. So there is a real problem with polypharmacy, and it's not surprising that patients are often not following medication regimes as they've been prescribed. We have the advantage of going into patients' homes where we can really see what is and isn't being taken. And we can try and adapt our regimes more closely to fit with the individual patient and their carer. But it is really difficult sometimes. So what do I think of the core skills, not just in pain management, but symptom management? I think we have to be very familiar with common medications, their pharmacokinetics, formulations, dose equivalents, side effects, and above all, access. But really, it all lies in communication skills. I think in exploring patient and carers' concerns, making sure we're working towards the same goals. If we can all be agreed that patients, carers, healthcare professionals are aiming, say, to have the patient being able to go out for dinner again, that's the goal. And the symptoms are just the steps to getting there. And we need to be able to provide information in a way that's understandable. Some sort of
I'm sorry, Sylvia. In the interest of time, we can
allowing patients to talk is therapeutic. We need to be aware of the impact, and identifying the patient's priorities helps direct treatment. And I leave you with this. I haven't given you a lot of pharmacology because it's all there to be looked up. So that was my race through symptom control.
Thank you, Sylvia.
We do a 3-day workshop on this.
Yes, very, very nice introduction. We shall now move on. If there is any question about symptom control to Sylvia, kindly put in the chat. We will try to answer the question. For now, we shall move on with the MDT. May I now invite a few consultants to join us in this session. Dr. Harinthiran Vijeyan is a general surgeon from Ampang Hospital, Kuala Lumpur. He will be presenting a case to be discussed after this. This case will be discussed with our 4 esteemed panelists in this MDT. Audience members are encouraged to type in your questions in the chat box. May I invite our panelists from Pantai Hospital, Kuala Lumpur to log in. I shall welcome Dr. Ummi Affah Muhammad, a primary care physician from Pantai, Dr. Patricia Alison Gomez, our breast surgeon, Dr. Malwinder Singh and Datuk Dr. Lam Kai Singh, both oncologists from Pantai, Kuala Lumpur. Thank you. Dr. Hari, can you share your slide? Oh, it's on now. Full screen, please. Yep. Okay, you may begin.
Hi, good evening. Can you hear me?
Yes, yes.
Hi. Yeah. So my name is Hari. So I'll just present a case from a hospital Ampang regarding a young lady. She's 36 years old female, Miss N, a Malay lady with underlying ASA1 ECOG syndrome, with underlying bronchial asthma, which is well controlled, and history of right breast fibroadenoma. And she underwent an excision biopsy in 2011 and also 2012. Her current breast swelling is only 2 years and progressively increasing in size. It's not associated with pain or any nipple discharge. However, since 2 months ago, she started developing bilateral lower limb pain. It was initially was occasional, but then it became more frequent. It has sharp shooting radiculopathy type of pain, bilateral inner thigh, with associated with difficulty in ambulating. She has an antalgic gait, requires walking frame due to pain and weakness in the frame. She only requires it recently. Her risk factors includes actually not very profound except for the paternal undiagnosed with breast cancer, which is not very. And she's nulliparous, not on any OCP. Menarche was 13 years old. Her menses are irregular. There's no dysmenorrhea. Her menses is actually once in every 2 to 3 months. She's working as a telecommunication executive manager, stays with her parents, good family support. She has 1 younger brother, single. As mentioned before, her bronchial asthma, she's not on any proper follow-up, though she doesn't have any ICU admission or intubation. The past surgical history is only right fibroadenoma, which was done earlier, and HPE showed to be fibroadenoma. During the presentation earlier, she had a left breast swelling. It was about 3 times 3 cm. Breast mass at 6 o'clock position. And also, but the lymph node was slightly bigger than the mass itself. It's about 5 times 6 cm. Right breast has no issues. And the ultrasound breast shows left lobulated breast lesion with axillary lymphadenopathy. It was BRATS 5. And there was a TrueCut biopsy done, which showed left invasive breast carcinoma. Estrogen receptor was positive, and progesterone was negative. CRB was also positive.
Hold on, Hari. We shall stop at the slide before this. At this point of time, may I ask our panelists, Miss Pat, are you here?
Yes, I am. Yep.
What would you have done for this patient if this patient at this point of time?
First thing would be MDT meeting.
Very good. Good. Very good.
Yeah, this is definitely someone that requires a lot of additional support, and you would need to have the oncologist, the pathologist, radiologist also on board before we make any more decisions about her. You can see that she's going to need a little bit more imaging to know exactly where the problem is in the spine. She will then need either neoadjuvant. We're looking towards neoadjuvant treatment for her because the local disease is advanced. And of course, she will need a lot of psychosocial support as well. So it will be very good if we can have an MDT for her with the family involved as well.
Thank you, Ms. Pat. What imaging would you request for at this point of time?
I think basically a simple X-ray of the spine first to see if she's got any obvious collapsed vertebra, and of course the gold standard would be an MRI of the spine. You can sort of target your MRI to a particular part of the spine if you've got a plain X-ray of the spine first. She would also need staging, so that would include a CT scan of the brain, of the whole body basically, or a PET scan if it's available in the hospital.
Would you send her for genetic testing at this point of time?
At this point in time, probably not just yet, because the additional treatments usually come, number one, they're humongously expensive, but yes, at some point in time, you would need to know if she is a BRCA gene carrier.
Thank you. Hari, do you have any, you have the next slide?
Yeah. So this CT staging, impression from the CT staging, which shows left retroalveolar mass, axillary, left supraclavicular, mediastinal, hilar nodal metastasis, and also shows extensive bone metastasis, which includes multiple vertebral levels and ribs. I have Dr. Premila will go through the CT scan in detail later. And also there's right thyroid cystic hypodense nodule, which we will do ultrasound later. So
Hari, we will go back and put it into our MDT on our further management, and we will see what goes on in your actual patient. Would you want to show us your CT scan?
Yep.
Thank you.
One moment, Dr. Premila is studying around. She will be showing the CT scan. One moment.
Sure. Meanwhile,
Guys, have you got a camera? It'll be nice to see you, Hari, and Premila as well. I haven't seen Premila for a long time.
So I will stop sharing for now.
Sure.
Yep.
So she can share. Okay. So yes. And okay.
You're muffled, Dr. Pram.
Okay. Can you hear me now?
Good.
Okay, all good?
Yeah.
Okay, so basically what, so the patient came in, we first did an ultrasound breast for the patient on the 5th of October. The patient basically had a series of ultrasounds in 2010, 2012, 2016. These were all basically showing fibroadenomas. Then the patient came to us in 2022. Okay. At which point she had an ultrasound done, which showed a BIRATS 5 lesion. A core needle biopsy in January of 2023 revealed a left invasive breast carcinoma, and we did a CT scan for her on the 13th of February. Right, so this was the ultrasound done on the 28th of December, and you can see a periareolar retroareolar lesion, right, with enlarged left axillary nodes with loss of fatty hilum. Okay, the CT scan, I've just basically taken slices of the CT scan to show you. She had very extensive bone metastasis, both lytic and sclerotic, right, with collapse of the L2 vertebral body, right? In the right lobe of the thyroid, there is a nodule there. And these are slices of the axial slices of the thorax showing the homogeneously enhancing mass at the left outer quadrant with associated skin thickening. The mass shows areas of speculation, seems to demonstrate no infiltration of the pectoralis, underlying pectoralis muscle. Okay. She also had a fairly extensive mediastinal lymphadenopathy. Right. Yeah. So those are the slides.
Thank you, Dr. Premila.
Premila, was a CT of the brain done as well? Did you include the brain?
No, a CT of the brain was never done. They only the thorax, abdomen, pelvis.
Dr. Pat, would you have done a CT brain for this patient?
She's got symptoms related to well, obviously cord compression at some point. You would like to know whether she has brain metastasis, and this is very common in your HER2 positive patients. So as a baseline, I think yeah, I would have done a CT brain as well.
Yeah, okay, we can address that issue actually. We can do a CT brain and a lower lumbar MRI. Because that's where she had a collapsed vertebra.
Okay.
So lower lumbar is the area of collapse, is that?
Yes.
Okay.
The L2.
So Dr. Ummi, at this point of time, it looks like this is a stage 4 breast cancer, locally advanced in a young lady. What would your approach be in terms of symptom control?
See her first, obviously, and be clear what she understands from her disease and what are the hopes that she may have, okay? It would be good if I would see the parents and the brother, because she's not married. I really need to establish what's this, psychosocial support that she has, and, the financial aspect of things, and why would she, to know her, why would she kept these lesions not being investigated for 2 years, isn't it? Even though she had fibroadenoma before. So there's a lot of things that needs to be explored, getting to know her. We may not have enough time, but getting to know her is always the best in terms of managing her later. She will have a lot of other symptoms, mainly pain and then the cord compression. She will lose her dignity, being dependent on others. The bowel, bowel regime needs to be addressed, and that's not easy. Has anyone talked to her about what her expectation, or where would she see herself from now to, let's say, 2-3 months ahead?
So yeah, when we met her in our clinic, we actually told her that this is a metastatic disease. However, on the good signs, ERP are positive, luminal B. It's not totally. It is bad, but we can still give it hormonal therapy. And also the thing is, we aim to refer to oncology in HKL, and then we did refer finally, and then she agreed for chemotherapy. She's actually a very understanding patient, and she's very independent, I would say. That type of patient. Okay, yeah. To tell the truth, I think she's the one who's taking care of the parents and everything. Yeah, so she's like very independent and very strong person. But of course, any disease can break even the strongest person.
Definitely.
This type of disease. So I'm not sure what will happen in the next few months when the radiculopathy gets worsened and the cord compression worsens. But for now, she just underwent the first cycle of chemotherapy. And we are aiming for some surgery, mastectomy later down the line.
Has she got symptoms, pain? I understand that she's on morphine. Is she taking it regularly?
From the last conversation we had with her, she does take the frequency has increased, but she actually can't say how frequent. But she does say that the pain is much more frequent now. In that way, it's just maybe may require other type of painkillers. But I think the oncology team in HKL have started her on. They started prescribing her on regular morphine, and I think she's supposed to meet one of the clinic review in this week to actually get a different type of pain management. I think maybe some neuropathic drugs will be prescribed for her. I think I'm not sure about that.
Okay, she may need. I think she will definitely need a neuropathic agent, and also the morphine. You can start calculating how much she's needing in 24 hours, and started her on MST, morphine sulfate tablet, which is a long-acting ones. And make sure that she's not constipated. That's the main thing at the moment. Looking into the mouth, looking for thrush. She may have oral thrush. Not being that well. That's about it, really, symptom-wise. First,
Ummi, can I just interject and ask the oncologist if she's a good candidate for radiotherapy to the spine for pain control?
Yeah.
Lam, Malwinder, anyone?
Yeah, sure. Because she has a lot of changes in her spine, and there's a lot of compression there also. So if the pain is not well controlled with pain management, we can always offer radiotherapy. And it's just at the lower lumbar region. You're not going to get a lot of side effects at that area. And of course, our radiation techniques have improved quite a bit. So you can actually just do SPRT or MRT and actually reduce her pain a lot. But before giving radiation, I would actually get my spine surgeon to have a look first, because to me, it looks like it's not a very stable bone there. I'm not sure whether the spine surgeon would want to do something to strengthen the bone there. Because once if I give radiation and later on she develops into problem, it's very unlikely a spine surgeon will want to operate on her. So get the spine to see her first, and then later on I can offer radiotherapy if they are not going for surgery. And of course, we can also add bisphosphonates for her, because like IV zolinodonic acid or something, because there is evidence to use zolinodonic acid in a stage 4 bone met patient for breast DA.
Is there a role of steroids before you give spine radiotherapy?
Only if the patient actually has symptoms of cord compression, I would actually start steroid, because radiation itself will cause some sort of edema at that area. If the patient doesn't have any neurological symptoms, it's quite safe to just give radiation. But if they have any neurological symptoms, then definitely we will start steroids first, and then together with the radiation, we will continue the steroid and taper down subsequently.
What's her calcium like? Because that's another thing that needs to be addressed. Mr. Hari?
Hari, do we have the calcium?
Yeah, hi. The calcium is about 2.3 to 2.4. I know, and the ALP is about 200 plus.
Not too bad.
Yeah.
One more thing, Dr. Ummi, if this patient presents to emergency department with acute pain like that, what would be your choice of medication if she has not been on any medication?
I would titrate the morphine. Be there, do that, the titration. The safest would be subcutaneous morphine, but if she can take it orally, encourage her to take the morphine immediately, hourly, until the pain score is acceptable to her. Many patients are are quite happy to accept the pain score of 1 to 2, but some patients has higher pain tolerance and they are okay with 3 to 4. But usually we try to aim the pain score between 1 to 2 and encourage her. She may not want to take the morphine because of the stigma that attached to it. Address that first. That the morphine will be excreted via the kidney, will be gone within 4 hours, not going to cause addiction, not going to stay in your body. And the pain increases the consumption of your energy. So That's that one patient needs to know, because
Would
they
you
are
play with paracetamol and coxib first before morphine?
well, you can add on if your morphine kind of fails, but usually correct dosage you wouldn't need to.
So first line morphine.
I would do so at this advanced disease. It's almost everywhere and she's in pain.
Because I think Sylvia
Can I
mentioned
just
something
ask-
about paracetamol addition of multiple.
You can, but you would like to be efficient and less, less tablet burden. If you don't need that, then you don't have to, because opioid is quite safe if you do a proper titration. Don't be afraid of it. Anyone with APC can prescribe morphine.
Okay.
Dr.
Malwinder,
Hari, can I ask what was the morphine dose which was started first?
Our initial dose was 5 mg. Serum morphine 5 mg first.
How frequent?
4 hourly.
Hourly,
We
okay.
started out the dose, and then after that, she got the immediate referral to Onco in HKL. So then after, I think they also started managing our pain management for her over there.
Okay, that's good actually, because I do see some of my colleagues actually, they have the idea that cancer patient, you need to start morphine, but the dose is completely out. I've seen a lot of patients being started on 2.5 milligram morphine for TDS or PD. They don't understand the morphine is actually a very short acting thing and it has to be prescribed very regularly. So yeah, that's one thing which I think we need to stress out, that the dose, you have to start 5 milligram and it has to be 4 hourly. And don't forget the laxative.
Yeah. If she's established at 5 milligrams and you think the pain is still not controlled, just convert it to MST. So if she's needing like 60 milligrams per day, then give MST 30 milligrams twice a day. And then in between, she can still take the syrup morphine for breakthrough, and encourage her to take it even after, even hourly. Control the pain better.
Okay.
Okay. Just now Hari mentioned that you wanted to do surgery after referring to oncology.
Yes.
What is our oncologist's opinion? I think we have Datuk Lam. He's not in here anymore. Malwinder, would you like to comment? Or Miss Pat?
I let the breast surgeon comment first.
Well, yeah, I don't think there's any role for surgery here. She needs basically systemic therapy at this point. And it's going to depend on how she responds to the neoadjuvant therapy. If the tumor shrinks appreciably and doesn't start fungating, the only reason to do surgery here would be really if it started fungating, bleeding, and got infected. I think that would be the only role for surgery, and that would be more of toilet surgery rather than curative, yeah. So I don't think there's any role for surgery in this patient at this point in time. What she needs is systemic therapy. You can see that she's HER2 positive. She's also hormone positive, and therefore you have many options to use for her in the neoadjuvant realm for her. I think a lot of it is going to depend on the finances, and therefore, she's not a government servant, and therefore, you really need to talk in detail with the patient about finances. The targeted therapy alone is going to bankrupt the family, I think. We don't even start on all the CDK4/6 inhibitors with hormone if you want to be a little more gentle. So yeah, I think no role for surgery at this point in time. She needs, unless you're considering spine surgery. Spine surgery would basically be to shore up, to strengthen the bone so that it doesn't collapse and land her up in paralysis. But other than that, no role for surgery at this point.
Yeah, our oncologist, any opinion about surgery?
I agree with Dr. Patricia, because one main problem is if we do any major surgery on her, she's going to take time to heal. And by the time she heals, her disease will actually progress much more. So for me, for breast cancer surgery for stage 4 is, we have to tell the patient that there's no survival benefit. It's just for local control. It might improve the pain, improve the bleeding. If it's fungating, you can remove it purely just for cosmetic reasons. But she definitely needs systemic therapy first, shrink everything, and then we have a discussion with her. If the tumor is still causing her symptoms, then we remove it. But if say the tumor doesn't cause any symptoms, then just leave it, because I don't see a point just removing the breast and there's other disease all over the body still. And being hormone positive, HER2 positive, her treatment will be carried on throughout until the disease is under control. So they can go on with it for months to years.
Actually,
Hi, Lam here.
Hi.
Yeah,
hi.
sorry, I couldn't get in earlier on because when I was trying to unmute, it asked me to go back to my phone and do the privacy thing and unmute my phone. I agree with what Pat has said earlier on and Malwinder in the oncological point of view, and so what Ummi has mentioned. This is a stage 4 cancer patient. She's a young executive. She's active. I think I will sit her down because she's single and talk to her about, explain to her this is stage 4. Explain to her the objective of our treatment, i.e., unfortunately, is palliation, but in the single breath, prolong her survival for as long as we can with best quality of life. I'm not sure about the cord compression. If there's anything below L2, I'm okay. It's just pain control. I don't think she's be threatened in terms of cord compression. And Malwinder earlier on said, obviously, surgery is not what we want to do. It's a bit aggressive. You go in, you take a lot of time to heal, but she's got a lot of tumor burden that we can see. So I would assess her in terms of she really has, so bad a symptoms that our oral or analgesics cannot control. Because when you start the systemic treatment, and all these areas which are of concern will actually start to, gradually improve. It does take time. We have to watch her very carefully. And if the pain can be controlled with analgesics, minimal intervention, apart from systemic treatment, I think we can get quite a lot of good quality of life for her. Now, one of the problems that I've seen, and I've treated patients like this who presented with very long history. Now, one of the other problems when we treat with radiotherapy is the bone marrow actually gets compromised. When you start to give them systemic treatment, you find that it becomes a little bit hard to control here and there, and then you're delaying treatment and things like that. So I think sitting her down, explain to her and the objective of treatment. Now, she's single. I would also want to get the family members involved from day one for them to understand that at some point in time she may need social support and care at home. See, so the family members can also be involved from day one to know what we want to do in terms of the objective of the treatment. And having settled that, I think then we go on with the treatment. Obviously, the treatment involves various regimes. She's HER2 positive. In the private hospitals, we do have access to targeted drugs, and obviously we would like to do that upfront. But in reality, we are again faced with financial problems that patients have. We sometimes have to end up choosing second best treatment. But that's the reality in life, unfortunately. But providing her as much as possible best quality of life as we go on with the treatment, I think it becomes very important.
Yeah, could I just chip in, Mizzy, because I think there is a randomized control trial on metastatic breast cancer, and it has been found that actually by doing surgery on patients with stage 4 cancer can reduce their quality of life. So compared to those who had surgery, their quality of life is actually poorer. So even though they don't have any survival differences, but quality of life is indeed reduced with surgery. So I think we have to sort of remember that, surgery is not the first thing we do. And I'm sure, Mr. Hari, you're very lucky. You got your CT scan very quickly. So, to get someone diagnosed with stage 4, I think in Ministry of Health is very difficult, isn't it, Mr. Hari? Would you like to comment on that? staging CTs are not that easy, right?
Yeah, actually not that easy, but I think in Ampang it's quite okay that we get our staging CT is quite fast, and we can they can accommodate for our MRIs also, in comparison to other hospitals that I worked with.
Yeah, also, I'm sure it's difficult to, I mean, it's so nice you have a palliative physician in this panel, but would
Yeah,
it be
thank you.
possible for you to have access? Is it accessible right now?
Actually, I just found out that we have a palliative physician that's being posted in Ampang now, about a week now. But I think it's
In
going to
time.
be official soon, and they're going to set up the department. And we got the
This
news.
is all because we are having MDT, you see. So immediately they posted someone there.
And I even heard there might be an oncologist here, but I'm not sure about this. This is just rumors going around, and it's good. So we can finally have an in-house MDT too. I mean, palliative physician here, oncologist here, surgery, yeah. So,
Just to chip
and, yeah.
palliative care physician now, can you?
Yeah.
What were you saying? We didn't hear you. Sorry, we didn't catch what Sylvia was saying.
There's definitely a palliative care physician posted to Ampang now. Can you?
Yeah, there is one, but they haven't released the official letter to us yet, providing the service. But I think there is one palliative care physician here. I think it's just about a few weeks back, 1 week or so. So I think soon there will be a meeting and they will release and the procedures and everything.
And
we'll get
Hospis
introduced
does
to him.
cover Ampang, isn't it? The coverage of Hospis Malaysia is actually quite wide at this point of time in Klang Valley.
We definitely cover Ampang. Our coverage is shrinking because sort of combination of population density and difficulty recruiting people to work in the community.
Before we forget, can we get her nutrition up to the best standard that we can? You can just refer to dietitian. Being Malaysians, you will hear a lot of pantangs. Some is ridiculous, but you just need to convince her that the more nutrition that she has, the more chance that she has with systemic therapy, because she needs to get all the nutritions as much as she can.
Thank you. Yeah, will do.
Okay. Let's say the patient have had good symptom control now. In terms of disease control, what would be the first line that you would begin for this patient, for our oncologist?
I think analysis 6, as mentioned earlier on by Dr. Ummi, sounds very reasonable an approach. Starting with a small dose to begin and then step up and see how she goes. You will be surprised, actually, some of them, despite morphine, don't stop the pain. But don't forget, sometimes even paracetamol itself is enough to stop the pain. The pain thresholds are actually very different from one patient to another. So I would start basically with that. And obviously, the primary problem is the breast CA itself. So systemic treatment, as you start concurrently, you start to run, you find the patients will start to improve dramatically. Don't forget, she also has bone metastasis, so recheck her serum calcium. She may require some bisphosphonates to try to stabilize, because hypercalcemia do cause a lot of blood problems as well, or constipation, apart from being added with your morphine. So I think, and I'll just say start with systemic treatment to go on.
Let's say the pain is well controlled now. What would be your, from the oncological standpoint, in terms of systemic therapy, which would be your preferred or the first line for you in this patient? ER positive, PR weak, I think, and then HER2 3+ advanced breast cancer in 36-year-old.
She's young, she's got such a large tumor burden. HER2 is positive. I would certainly, if cost is not an issue, would start with Herceptin Perjeta combination with chemotherapy. Studies have shown, obviously, of course, this is the best combination that we would like to get in and downstage as much as the tumor as we can. And obviously, that will also help her with the symptom control.
Yeah. So chemo plus targeted therapy, anti-HER2, two types. And when would you start a hormonal therapy?
Hormonal therapy, she's stage 4. In an ideal world, she would get on with maintenance Herceptin Perjeta as the maintenance treatment. The hormone would probably be much later for me. I wouldn't even put her on it. And having that in mind, but maintain with the Herceptin Perjeta. Malwinder, would you want to add on or think otherwise?
Yep, I agree. Normally, we
Can I just say, I think you're hoping that the chemotherapy will render her menopausal, is it?
Possible. You want to render her menopausal?
Possible, but then you wouldn't. I don't think if I've completed her chemotherapy with the Herceptin Perjeta and then ignore the Herceptin Perjeta and put her on a hormonal treatment, then I think I will putting her at risk.
Yeah.
So I agree. Start chemo first with dual HER2 if possible. So this patient is going to be referred to HKL. So in HKL, they do have Herceptin. Unfortunately, it's only listed for the adjuvant setting, but with KPK approval and all, and I do hear that nowadays they can get it early on. So you can actually just start on chemo and Herceptin for her in the KKM setting first. If money is not an issue, she can actually buy the dual HER2. They just buy Perjeta and they get Herceptin free. So once she complete her chemo, depending on what regime we choose, 6 cycles or 8 cycles, then we just do the maintenance dual HER2 and you can add on your hormone later on with that. So the hormone will depends whether she's actually menopausal or not menopausal. You can of course just add goserelin or some GnRH analog to make her menopause and continue with some AI if possible. But otherwise just tamoxifen plus the HER2 treatment as maintenance.
I think it's good to realize at this point that if she's got only bony metastasis, even though it's many, I think she will actually do quite well. Yeah. You find that bony metastasis, even though they're multiple, don't do as badly as solid organ and of course brain metastasis. So, brain metastasis is always the, oh no, oh God. But, the solid organ and would be the next one. And then bone metastasis, somehow we have learned to manage it a lot better with the treatments that we have, including radiation therapy if necessary for the pain control, bisphosphonates, as Malwinder mentioned. And you find that they actually do quite well for a long time. I've had patients in the same scenario well after 15 years, just continuing with bisphosphonates, continuing with the hormone therapy. We don't stop the hormone therapy. They were very, I would say, clever in the sense that they decided earlier on that they would go for bilateral salpingo oophorectomy, even though they were single. And I think it was more a question of survival rather than having children in the long run, and therefore they agreed very easily for the BSO. Whereas and they've actually done very well on just we managed, because once they had the BSO, then we could switch over to the AIs, and they've actually done very well, very, very well. Touch wood.
Yeah. I agree with you, Pat. Bone metastasis, CA breast patient is a little bit different from our visceral mets patient.
Correct.
They can actually go on and on, with some maintenance treatment that you give them. The only problem with bone metastasis patient is this problem, skeletal related events that if they ever have to happen. But if you strengthen that, yes, true, they can actually go on and on for years actually.
Yeah, my patient is 15 years, still doing well. She was diagnosed when she was 27. 27, she's married. She's married, but the husband was very, very, on board and said that, it's fine if we really decide we want to have children, we'll adopt, which I thought was excellent.
Yeah. So I have a patient like that, more than 10 years. I see her walking around in the morning exercise.
And when the treatment works, you can titrate down the morphine. It doesn't always be up titration. You need to down titrate it as well as the pain is better controlled.
Do you have a lot of problem with nausea and vomiting in young ladies when you initiate morphine, or do you just start morphine plus Maxolon?
Yes, I do start morphine plus Maxolon the first 3 days, warn them, educate them about the side effect, but the constipation will stay almost forever as long as you are still on opioid. They generally do quite well. Of course, morphine has higher side effects compared to oxycodone and fentanyl, but most people are able to tolerate it and body adjusted quite well. After a few days, they normally don't really have much problems with it.
Yeah, because I see quite a number of giddiness, and they stop their morphine completely because of giddiness.
You can space it up and then, prescribe Maxolon the first 3 days to avoid those side effects and to gain their trust, really.
Okay, I think we have 5 more minutes. If there is any question from the floor, we are ready to take a question at any point of time. But otherwise, we will end with what the patient had from Dr. Hari. But just to make it a bit more complicated, let's say this is a BRCA2 patient. What would you change in terms of, would you start olaparib, PARP inhibitor instead of a Herceptin? Or just continue with Herceptin dual blockade?
I will continue with Herceptin with chemotherapy with dual blockade. Keep the PARP inhibitor in mind as one of the salvage treatment.
Malwinder?
Similar, because the evidence to use dual HER2 is far more evidence available and much more. They don't have head-to-head HER2 with olaparib, but if you look at the response rate, HER2 dual blockade is actually far more superior than olaparib.
Yes,
must have very, very deep pockets.
Yes.
Yeah, true.
This is quite surprising because I see that the history of this patient, she have had multiple surgeries in Gleneagle, and somehow when she presented at this point of time, it is already advanced.
So, office GL, the first few.
Yeah. So
must be office GL.
But 36-year-olds should still be in office, isn't it? Yeah.
Yeah.
So there are some questions from our audience. Dr. Hari, do you have some blood parameters or those? There's a question on blood parameters.
Yeah, so most of her bloods are actually normal. She's young, she was quite healthy. Even her calcium was normal. Actually, to see the CT scan and then I saw the calcium and the ALP, didn't really, for me, didn't really correlate. But everything else seems to be normal. Her HB is normal. Her albumin is good. I think it's about 40 to 43 or something. LFT is normal. There's nothing that I could point out remarkable.
Okay. So in hypercalcemic crisis and bone pain, Dr. Ummi, what would you start?
Hydrate, obviously, and then make sure the constipation is dealt with, hydrate, and then you can just give either pamidronate or Zameta, either one that's preferable. If the bloods are fine, like the kidney profile is okay, you don't have to dose adjust it, and DEXA to bring it down faster.
Thank you. There is also another question. Is there any role of curative surgery for single or less extensive bone mass?
I suppose that question must be for me. Hari, would you like to take a go at it, Hari?
Me? Okay, so for me, I think if it's a single bone mass, I will treat it somewhat like locally advanced for now. But if it's multiple like this, then I will treat like a metastatic bone mets.
Yeah.
So I would
think,
go surgery.
Yeah, there are two things here. One, it is locally advanced in the breast, in the axilla. And then if you find there's just one bone metastasis, you still go for neoadjuvant systemic therapy first. You need to treat everything, not just one thing. You always need to remember that surgery is local control. It doesn't control the systemic disease, and therefore neoadjuvant chemotherapy with Herceptin, Perjeta is still the treatment of first choice.
All right. Maybe we should end the session. Hari, can you show us what happened to your patient? I think you have two.
Actually, the balance slide is actually only one slide. So it's basically we refer to oncology. We started her on morphine, and the onco team has planned for her 6 cycles of chemotherapy. And she did mention over the phone that she was started on Zometa. She could mention the drug name, but about Herceptin, she's not very well. She was informed about a drug which she had to send for kebajikan or something like that. We will be seeing her in 1 month time actually, which is going to be in a couple of weeks. She just finished the first cycle.
Thank you very much. I think we can end the session now. It's almost 9:20. In good time. I would like to take this opportunity to thank all our speaker, panelists, and presenter for joining us today and this great initiative and the effort to improve standard of breast cancer care in Malaysia. To all participants, thank you and welcome to join us for our following session in 2 months' time. Indeed, a very exciting session, and I reckon that these MDTs will improve overall breast cancer care and outcomes in Malaysia. Thank you for your patience and have a good evening. Bye-bye.
Thank you. Good night, everyone.